Thank you. Good morning, and thanks, Dr. Reel, for putting all this together. I want to thank you for letting me talk about evaluation of thyroid nodules. When he first asked me, I kind of chuckled because it seems like a really simple thing. You have a nodule, cut it out, but it's not quite that simple, and a lot of the complexity in the algorithm of making the decision is based upon the fact that a lot of thyroid surgery has been done where we remove a nodule and it ends up being benign, and certainly we would like to limit the amount of morbidity and mortality on patients associated with unnecessary surgeries for a nodule that maybe looked like it would be a problem and wasn't. So when I have residents rotate through with me, I say it's still pretty simple though. Most things are evaluate with history, physical, and then do some studies and you make some decisions, and we'll basically unpack all that and try to help you with the management and algorithms. So I have no disclosures. So I went to a meeting a couple years ago, and Ashok Shah, who's a big thyroid surgeon at Memorial Sloan Kettering, said, and he has this really thick accent, he said, "There have been more articles written on thyroid nodules than there have been thyroid nodules removed." And he says, "And I am sick of Dr. Google. They come in every day and they tell me what I'm supposed to be doing." So, and I hope that that accent doesn't translate in any way, shape, or form. But anyways, I really could feel that sentiment because there's so many articles and there's so much information that it becomes a little bit overwhelming on the algorithm of what are we supposed to do. And now there are new ways of evaluating these nodules, including biomarkers, and so we're going to go through some of these things. So some of the objectives, first was to assess risk factors. So we have history, physical, and exam, and then we have our studies. So risk factors are a big part of this, and we'll go through those risk factors. We'll identify some of the ultrasonography characteristics that will tell us that maybe this nodule isn't such a good nodule. Understand some of the fine needle aspiration results, and then the decisions that we can make off those results, and evaluate biomarkers as something maybe additional that can help us to limit the number of patients who have unnecessary surgery. So this is an easy one. I think you would walk in and see this right away. But obviously, a lot of the nodules we find are found incidentally. You get a scan, and it's like, oh, there's a nodule. I better work this up. Or you are feeling a patient, you're like, do I feel a nodule? I want to just remind you, get behind the patient and feel with the broad surface of your fingers and to feel into the groove, the paratracheal groove, to feel those nodules. After I get an ultrasound and I feel the nodule, it's sometimes so obvious. But if you do it quick and you really don't pay attention, it's very easy to miss some of these nodules. So epidemiology, there's a lot of nodules out there. 7% of every human being has a nodule, and that increases to 50% by age 50, and they say almost 100% by age 90. So I had an old mentor who said, there's 1 in 13 patients have a nodule, go find us some surgeries. So there are a lot out there, and you should be feeling a few just by sheer odds of the number of people that you see. That doesn't mean they all need to be cut out. Now, the incidence of thyroid cancer has been rising, and that rising probably has a lot to do with the modes of the modalities of detection, and more studies being performed, more things being found. However, over 30 years, the incidence of death from thyroid cancer has not changed. It's run roughly between 1,500 and 2,000 a year for the United States, and it's stayed that way for a very long time. This year there was 54,000 new cases, or they're projecting it as the number that have been laid out. And like 3 years ago, it was 60,000 new cases. But overall, they have been rising. If we just did autopsies on every random person, they find somewhere between, depending on the study, because it's sample studies, 4 to 30% incidence of cancers in autopsy patients. That's a big number, and that's these micropapillaries. So, there's Ashok Shah, not to reference him too many times, he said, there's certain kind of cancers that will just live with you. And this can be one of them, where you'll have the cancer and it doesn't necessarily mean it's going to progress to the type that's going to kill you. At this point, we don't really have a way of telling somebody which one's going to do that, but we got some indications that will help us in guiding our surgery. It's actually more common in men than women, but more cancers are identified in women than men. And that's because probably women have, on average, a little bit thinner necks, a little bit easier detection, and they also have more regular health care. They go to the OBGYN, they're going to get seen a little bit more and maybe have things found. 80% are papillary thyroid carcinoma, and you might want to remember that for the questions. 98% relative 5-year survival if you develop thyroid cancer. And we'll go through some more on that. But basically, it's a cancer that has a very high survival rate. People do very well. I think I read one study that said more people die of tuberculosis still every year than die of thyroid cancer. Okay, so this is actually a patient of mine who presented. When she came in, she was an older lady who was complaining about hoarseness, and she actually had a pretty good voice. When I felt her neck, she kind of had this broad neck, kind of a short neck and high clavicles, and I thought her neck felt funny. And here I am, a surgeon. I do this all the time. And I was like, well, your neck feels really firm, and it feels kind of like there's a little bit of a mass here, but I really can't tell. And I did a CT scan, and you can see here this very large mass encompassing her trachea and displacing actual thyroid gland here, and then a lymph node over here that's metastatic. So symptoms can become a very big component of our risk factors and identification. So this is a lady who presented with hoarseness, dysphagia. When I put a nasopharyngoscope down her throat, I saw a big mass extending into her throat, and this was actually it. So what are some risk factors? So you have somebody who you've detected a thyroid nodule. The risk factors are going to help guide you on how serious you need to take this. It's not the only factor, but it does play a role in the decision-making process. So hoarseness and dysphagia. First thing we want to know, if they're having hoarseness and dysphagia, is there any kind of vocal cord paralysis, or one of the cords not working? Sometimes it's very easy to tell when they're talking like this, and there's a problem. And that's how they usually sound. But sometimes they don't sound like that. Is the mass, I don't know if you can see this very well, is this mass firm, fixed? Does it feel kind of wrong? Or is it soft and mushy and blottable like the thyroid can be? Do they have a history of radiation exposure? This is kind of a vague term, but I'll give you some specifics. I think right now you have to ask about Fukushima. You have to ask about, and that's the meltdown in 2011 in Japan. I mean, they basically have radionuclide spread all over that country right now. And they just had Nagasaki and Hiroshima. They're going to have like 100 years of thyroid cancer. Then you have to ask about people who've had breast cancer and breast radiation therapy. Those fields come up very high. This lady that I just showed you actually had breast cancer about 12 years ago and had radiation therapy, and here she is with this. Family history, so very many forms of radiation. I don't think that necessarily encompasses the radiation tech. They take a lot of precautions, and then people ask about their dental exams. There's a certain amount of kind of average radiation we experience, but still a good question to ask about. That's going to change if you have a nodule and they had this radiation, whether or not you need to take it out and find out if it's cancerous. Family history, there's a few familial types. We can go through those. Constitutional symptoms, weight loss, fatigue, a new pulmonary nodule, undiagnosed or diagnosed but unknown, hasn't been biopsied in the setting of a new thyroid nodule. Well, the two things to consider together. Certainly neck adenopathy. Do you have like lumps and bumps in the other parts of your neck? And I asked them, I go, do you have any other lumps and bumps? Talked about vocal cord paralysis. So I tell my residents that come through and rotate with me, I say, we want to know from the history very pointed questions. I don't ask random questions. I'm asking questions that help me decide what am I going to do with this nodule. So I wanted to give you an idea of what there is that grows in the thyroid. So certainly a lot of benign nodules. This is, I only have two hands. This is, there are follicular nodules, which is basically your adenomatoid nodule or colloid nodules. Then there's actual tumors. Yeah, this one doesn't work well. Thyroid adenoma is a benign tumor, but is certainly hard to distinguish sometimes from the follicular adenocarcinoma. Thyroid cyst, thyroiditis, hemangioma, thymoma, parathyroid adenoma, or parathyroid. Certainly, sometimes biopsying these things can mislead us, and the cytopathologist, if there is a biopsy performed, may get somewhat distracted by thinking it is a thyroid nodule. Certainly in the malignancies, there's basically 6 major ones. Papillary, we just said, was the most common. Follicular, medullary, anaplastic being the thyroid origin cancers. Lymphoma, there is some primary lymphoma of the thyroid, but most of it is secondarily growing into the thyroid. And then metastasis, you want to think about breast, lung, kidney, melanoma, and then colon cancer really rarely. well, all the metastases are pretty rare. So the workup, you have a basic set of workup studies that you can perform, and everyone should start off with a TSH and an ultrasound. You certainly could do a free T4 and a TSH, but a TSH is going to kind of guide you. If you got a nodule and you have a low TSH, you have to think possibly this nodule is an overactive functional nodule. If your TSH is normal or high, suggesting they actually have a low thyroid, then that still needs to be worked up, but for the instance of evaluating for cancer, that's a little less important now. And then we work on to ultrasound. We'll talk briefly about scintigraphy. That's your I-123 scans. Really not as much of a role nowadays for evaluation for thyroid cancer, but we'll talk about when it has a role. And then fine needle aspiration, and finally genetic testing or biomarkers for these nodules. So ultrasound has some very characteristic findings that the radiologists get excited about. So hyperechoic, hypoechoic, all has to do with how light or dark it is in comparison to the muscle and tissues around it on the ultrasound. So characteristics that would give us a very solid nodule are going to be not as good. And so, by the way, this is kind of a bullet point here, but malignant characteristics, greater than 2 centimeters, so a big nodule, something that's solid or hypoechoic, and hypoechoic suggests it's more solid. How hypoechoic? So if it's kind of light and it's a little bit lighter than muscle, that's a little hypoechoic, and that can kind of be an intermediate finding. But if it's definitely not completely black and it's a lot darker than surrounding tissues, then that's more hypoechoic, and the more that they go in that direction, the more worrisome they are for solid lesions. Something that's very irregularly shaped or has a lot of blood vessels that are a lot of blood flow in the middle of it, they're taller than wide on the ultrasound, or they seem to grow right at the edge of the capsule and kind of go through the capsule. Those are all going to have concerning features. They're going to place this at a much higher risk for being potentially malignant. And you're going to read these on the reports that you get. So if you can remember a couple of these buzzwords, you're going to say, oh yeah, hypoechoic and microcalcifications, which is the last thing I didn't mention yet. Microcalcifications, those two they're bad. So we're going to send them on and have them evaluated with a biopsy. If they're really hyperechoic or even spongiform, spongiform is kind of like a Swiss cheese or honeycomb. It's got this kind of like dark spots and lighter colored spots. And then a comet tail shadow, this one actually is listed, but it has some controversy on when it is more concerning. Or something purely cystic. So purely cystic or hyperechoic, those are two words that tell us pretty good, probably not so worrisome. So best pictures I could get of microcalcifications, you can kind of see some right here, you can kind of see some right here. And I think microcalcifications are something that we want to pay attention to, especially in the setting of papillary carcinoma. They form little smoma bodies we'll talk about in a second. So kind of bullet point again, 2 centimeters, solid or hypoechoic, microcalcifications, and then those other things I talked about. Is it right at the edge of the thyroid? Is it tall more than wide? Is it kind of irregularly shaped? Things that you want to refer on. And if they have these characteristics, there's a much higher chance of there being something malignant. There's a thyroid imaging reporting and data system created by the radiologist. You might see those on reports too. They'll say TIRADS 2, 3, 4. Just remember TIRADS 4 and 5, again, bad. They need to be moved on for further evaluation. The American Thyroid Association or the American Association of Clinical Endocrinologists, in these really kind of more concerning features, will recommend biopsies down to 5 millimeters. I kind of always grew up 1 centimeter, 10 millimeters, we start really paying attention, but they're getting, with these characteristics, they want you to be a little bit more concerned earlier, or at the very least, watch it very closely. All right, back to the I-123 scans. Really just best to try to evaluate if this was a functional nodule. If you're using this to evaluate cancer, it's kind of like, welcome to 2018. They just don't do that anymore. But there was an incidence where a cold nodule would tell us kind of a potential that this may be a non-functioning nodule and therefore maybe it's cancer growing. But when they did a lot of surgeries for this, we realized they were just getting so many false negatives that they just were doing unnecessary surgery. So we needed more modalities and we came up with them in fine needle aspiration. So fine needle aspiration is how we evaluate a nodule after we get ultrasound characteristics that concern us. So we had those high-risk characteristics. You remember the ones I talked about? And then you have the really low-risk characteristics. So what do we do with the low-risk characteristics if we get those? Well, we don't just throw it away. We still got to pay attention to them. If they're under 2 centimeters and they're low risk, you can just watch it. But maybe do another ultrasound. Or you could just follow it clinically and see if it's growing. But you do need to keep a little bit of an eye on it, because if it does grow, or if it starts causing them symptoms, then it still may need to be taken out. When it's the high risk, those other things that I mentioned, then you're going to definitely move on to evaluating it. And I said down to maybe even 5 millimeters. They recommended 10 millimeters, but the ATA is starting to push for lower. For the intermediate risk, what is an intermediate risk? I didn't define that. Kind of a little bit of this and a little bit of that. Maybe there's a couple microcalcifications. I mean, nothing is purely black and white in these things. I mean, it literally is black and white, but nothing is purely black and white. So, you know, you're going to have to try to understand that there's some times where it's a little hypoechoic, you know. Pathologic adenopathy. So you got a lymph node somewhere else that's not good, doesn't look right, it's rounded, it's way too big, or you have a needle biopsy that says it's cancer, then you definitely know you need to needle biopsy something in the thyroid to give you an idea of where it came from. Yeah. So less than 10 millimeters with risky findings, you could biopsy or you could observe, but you're definitely going to be watching that very closely. They don't recommend, so multinodular goiter, so you get somebody with multiple nodules, overall has a much lower risk of cancer, just all comers. And they definitely, so when you look at it, you're really looking at a couple or a single nodule and kind of changing your mindset to, I'm looking at this one nodule as maybe it is or maybe it isn't cancer. I don't think he has 7 nodules and developed 7 independent cancers. So they actually make very strong recommendations never to biopsy more than 2 nodules. It just introduces, there's already a little bit of error that is built into all testing, and you're introducing multiplications on that error by biopsying multiple things, and it could lead to a surgery that's unnecessary. And then you're not recommended to biopsy a functional nodule with FNA, but you may be cutting it out to try to stop their hyperthyroidism. So I got a couple slides for the FNA. Everyone remembers kind of orphan Annie-eyes and Samoma bodies. A lot of times they don't see those on FNA. I don't even think they do see Samoma bodies on FNA. What they will see is these sheets of cells, and when they pan out, it's like little sheets, and then they'll have these nuclei that have a lot of nuclear inclusions, and then there's sometimes cleaving, and then they'll have some grooves. And they're kind of flat like a sheet, but they have larger nuclei, and they're a little bit more spaced than, let's say, follicular carcinoma, where they're coming in very tight clusters. And so this is the way they look when they know it's cancer, and they're looking at this trying to make a decision with these needle biopsies on whether or not they are these things. So a needle biopsy is performed. It's done in the office or in the with an ultrasound, and usually take 2 or 3, sometimes 4 passes. And then they'll put one on a slide for immediate evaluation, and then put some other, sometimes in cytolite. Here's anaplastic carcinoma. It's anaplastic because it's lost its differentiation, and you can just see how much more irregular. You got some that are tight and small, and some are big and irregularly shaped, and they're not so uniform in their orientation. So when we had these needle biopsies to further evaluate nodules, they had to come up with some kind of system to evaluate and make a uniform reporting system. And they came up with the Bethesda system, which was produced by the National Cancer Institute in Bethesda, Maryland. And they had a statement of science conference to come up with this system, and they took some known cancers and some known needle biopsies, and they came up with this great system. The problem is there's a little bit of variation from pathologist to pathologist on how well they report within the system. But the system, when done correctly, actually gives us a lot of information. In a Bethesda grade 1, you basically have a bunch of cells maybe, or no cells, but they're not thyroid cells. So they're pretty clear that it's a non-diagnostic study for thyroid. You may see macrophage and blood and other stuff, but you don't have anything thyroid related that you can really tell what it is. Then there's a benign classification. They have very characteristic appearance of just benign cells from like an adenomatoid nodule. Atypia of undetermined significance, or FLUS. these are kind of where they look a little bit abnormal. Maybe they have some features of the papillary that I talked about, some of those sheets, but maybe not big sheets, so they can't really tell, and maybe some heterogeneous nuclei. Follicular neoplasm, it looks like a very characteristic follicular neoplasm, but because follicular neoplasms, when they're benign and when they're cancerous, are very difficult to distinguish by needle biopsy, they put them in this category. It has about a 15 to 30% incidence of cancer. And then they find suspicious or malignant. So malignant, they're very clear. It is cancer. Suspicious, it probably is cancer. Maybe we don't know which type, but it looks very cancerous. And this is going to be 60 plus incidences, 60 plus percent chances of malignancy. And really, this one, there's no doubt on what to do next. You're going to be going to surgery. This one, there's still not a lot of doubt that you're going to need to take this nodule out because there's a really high incidence of cancer, even if it is a benign tumor. At the very least, it's probably a tumor. This one is where there's a bit of wasted effort. So about 30% of people fall into that category, and when they do, we're looking at a pretty high percentage, because it's about a 5 to 15% chance of malignancy. You're looking at maybe 4 in 5 people having no cancer and you're doing surgery on them. So we would like to potentially decrease the frequency of surgery done on these patients so that we pick up more cancers and eliminate surgeries that are unnecessarily done. There is a good degree of morbidity and mortality from thyroid surgery. Most of us think of it as a pretty routine surgery done, and usually it is. But I read a study that showed 0.1 to 0.3% mortality. I think that sounds a little bit high. I think I've done enough to not meet that number. But well, no, that'd be 1,000. That'd be a lot. But I would say, you know, that's a pretty reasonable thing to consider when you're doing surgery. And then up to 11 or 12% of people who've had thyroid surgery end up in the emergency room within 30 days after surgery. So there's obviously some morbidity to it as well. So we want to improve this number. If we get a pretty benign looking ultrasound nodule and we get a benign biopsy, we don't necessarily even have to do the biopsy on that one, remember, but if we do, then we can be pretty sure this thing's fine and we can just leave it be. And if we have these, we know we have to do surgery, and usually it's going to be the whole thyroid, although I'll talk about that later. This one right here, I'm sorry guys, with the, this one right here, the follicular neoplasm, you're probably going to take it out and determine if it is cancer, and you may end up having to do a whole thyroid. But this one right here is really where the meat of the next part of the talk is, and that is what can we do to limit that? And what's been investigated is biomarkers. And what biomarkers are is a evaluation of the mRNA that is produced by the thyroid cells themselves. So we do the FNA, we get the cells, we have the cells sitting in some solution, and the cells still have made mRNA, messenger RNA. And as you know, that's coming from the DNA. It's transcribed, and then it goes to the ribosomes, starts making proteins. And there are transcriptional errors of the mRNA that are very classic for certain types of thyroid cancer. So it started out, I believe, at University of Pennsylvania, but they started finding some of these biomarkers, and they worked on these mutational panels. And then a couple of commercial companies saw the potential for revenue and did some investigations and found that they could, with certain panels, and these are proprietary, so you don't exactly know how they do their panels, but with certain panels, they can determine the mRNA that are being produced if they are a high chance of being from a malignant thyroid cell. And so Afirma is probably the one you're going to see the most if you have a patient you've sent to an endocrinologist or has had a biopsy and they've done some kind of biomarker testing. The next big one is going to be Thyrosec, and they're on the second generation of that one. And what these are looking for is the BRAF, the RAS, PAX8 and PPAR, and the RET proto-oncogenes. And we'll go through, they do them a little bit differently, but what they're trying to do is what we call a rule-out study. So they're trying, more importantly, to rule out whether or not this is cancer than rule in whether it is cancer. And the distinction is deciding the extent of surgery. In a rule-out study, we're trying to basically say, okay, this is benign enough to watch and wait. In a rule-in study, we're saying, okay, it's cancerous, and do we take the whole thing? So it's a little bit more of, it's what we call a negative, it has more negative predictive value when we're doing the Ruleout study. So we'll go through that in a second. It's recommended it's done at the first biopsy. It does have a little bit more efficiency and accuracy on the first biopsy. On a repeat biopsy, you do have some inflammation that's caused. And it's really for those indeterminate nodules, the AUS and the FLUS, those Bethesda class 3 nodules. So Afirma took that microRNA and did look for transcriptional errors. They actually do 2 cassettes. So first, they send through these panels. They look for melanoma, breast cancer, renal cell, parathyroid, medullary, and Hürthle cell. They do that first. If it's a parathyroid, it'd be nice to know right off the bat that you're not chasing a parathyroid. It may be an adenoma, but probably a different thought process than cancer. The other ones, you're going to immediately be thinking about metastasis, and I already talked about those. Then, but we're still talking about an indeterminate nodule, so then we test it for BRAF and RAS mutations, and those will determine to a percentage whether or not that negative predictive value has been satisfied. So when they did that, if they took an indeterminate nodule that previously had a 5 to 15% chance of cancer, and they test it with this test, and it does not show up one of those mutations, then less than 5% of those nodules will have cancer in them. And if it does show one of those mutations, more than 40% will have cancer. So it helps us make the decision about whether or not we can just ignore that nodule, or not ignore it, watch it more closely but not operate, or whether or not we have to move forward and discuss surgery. In 5 or 6, they don't do it. So if it's good for indeterminate nodules, why wouldn't you do it for the other nodules too? And these, they're already such a high risk of malignancy. You're kind of gonna enter in the possibility of a false negative, and you may be leaving cancer in. So by the percentages, we don't do it for the ones that we already think are cancer. So it's only for that indeterminate nodule. Here's a sample report. I just thought you might want, because you might see one of these in your office one day. This is a benign report, but essentially there's different categories in here. And if it hits that indeterminate nodule, it'll put indeterminate right there. And then we look for this GEC, which is their gene expression classifier, which is basically those markers I talked about. And if it is negative for that, they'll point this way and it'll be a benign. And if it's positive, it'll label this as suspicious and that 40% risk of cancer. And it labels it right, it's usually right here. I don't have it on here, but it usually labels it right there. And then it'll also test the BRAF after that. So Thyroid tried to compete, and they have a little bit better numbers, but the first one, Afirma, was done with a double-blinded study, and then they actually compared it to histopathology, whereas this one, they did a prospective study, and they did I think it was 600 patients. And so this one has better numbers because they did a bigger panel, but it's not as reliable a study. So it hasn't really been adopted by the major associations, but there's a lot of endocrinologists using this. So you might see the Afirma, and you might see Thyroid. So if you got that nodule and it says it's negative, the American Thyroid Association says you can observe. If it's positive, then it says you should probably do surgery, but it doesn't tell you what surgery to do. And then they do recommend the clinical laboratories in improvement amendments, one of those CLIA laboratories. So what are we going to do for surgery? So we have a nodule, and it's indeterminate, and we did a Afirma test, and it come back positive for that classifier, those biomarkers. We may want to take out a lobe that the nodule is in, send it to the pathologist, ask him what it is, and decide on surgery from there. If we know it's cancer and it's of a certain size or characteristic or risk factor, we may want to do a thyroid lobectomy or a total thyroidectomy. So when do we do those different things? And this is usually on our hands. You don't usually have to deal with this part, but we certainly can. So Japan had so many cancers that they began deciding, we have to kind of stratify. Do we have to operate on everybody? They took it to the extent where they actually were observing people with thyroid cancer and just leaving it in there saying, it's small, low risk, we'll just watch it. So I wanted to let you know a little bit of what the risks what makes risk factors. So under age 45, the risk of a poor outcome or a poor survival from thyroid cancer goes way down. In fact, if you're under 45 and you have one of the well-differentiated thyroid cancers, you are stage 1 and 2 no matter how extensive it is. I had a 19-year-old young lady who had a 7-centimeter lymph node in her neck, a 3-centimeter tumor in her thyroid, and she was stage 1. How is that possible? Well, because stage 1 under age 45 with a well-differentiated thyroid cancer is T anything, N anything, and no metastasis. And stage 2 is metastasis. So under age 45 is a very good predictor for the long-term survival. Doesn't mean they're going to have a rough go. There's going to be a lot of surgery, and they may have radioactive iodine, but their survival is very good. Over 45, everything seems to change. And if they, doesn't it? So, this is about to go. So if they're over 45 and it's a big tumor, so I didn't go through all the TNM classifications. I didn't want to bore you to death, but the T1 and T2s are less than 4 centimeters, and they're kind of contained within the thyroid gland. And the T3s and T4s are much bigger, and they're extending outside the thyroid gland, okay? So if they're over 45 with a big tumor or any lymph nodes or any metastasis, then they're high risk and their survival drops. But still doesn't drop that far. 87% chance they'll live for 10 years. The intermediate ones are going to be the ones who are under 45 with a big tumor and some lymph nodes, like my young lady that I had, or over 45 with a small thyroid cancer. And this classification system was based upon the Memorial Sloan Kettering risk assessment classification. So if we're going to do, I mentioned some surgeries we can do. First one we can do is a diagnostic surgical excision. So that is taking the thyroid lobe out to see if it's cancer. So that's the intermediate one. We're looking to see if it's cancer. Or the follicular adenoma, we're looking to see if it's cancer. So we can take out a thyroid lobe and do an intraoperative frozen section and then wait and determine, hear from the pathologist what he thinks. If it is when we do that, indications, indeterminate nodule with high-risk features or positive biomarker evaluation, rapidly growing nodule, high-risk clinical findings or clinical risk factors, so the radiation would be another one. And then symptomatic nodules, and in this one, we're probably a lot less worried about, I'm sorry, it's not showing up, but we're a lot less worried about the possibility of malignancy. But we do this surgery, and if the pathologist calls us back and says, this is papillary thyroid carcinoma, then we make a decision as if we had known it was thyroid cancer, what would we do? And I'll get to that a little bit more, but we make the decision whether or not we have to take out the rest of the gland or not. If it's benign, then we stop. And then sometimes they'll tell us it's a follicular lesion. We may or may not know if this is cancer, and we'll need a little bit more time, and then we may potentially have to come back. A thyroid lobectomy. It's actually indicated in thyroid cancer for a T1 or a T2. So not taking out the whole thyroid gland, but just taking out a lobe in a small cancer in a young person. Potentially saves them the radioactive iodine, which actually can cause dry mouth. There are some in the high dose radioactive iodine associations with lymphoma and bone marrow suppression. And then also with the radioactive iodine, some people get kind of dry mouth. So we'd like to save them radioactive iodine. And then certainly if they have half their thyroid, there's a chance they'll make enough thyroid to not have to take supplementation. And if they have half their thyroid and we didn't take out the other side, then low chance of causing hypoparathyroidism. So this is a reasonable option in a young person. So I wanted to quickly show you some anatomy before I got into the total. When we're doing thyroid surgery, you have to worry about a couple of nerves. This shows kind of the gland in its normal placement. It has an inferior and superior thyroid artery that gives blood supply. And then you have a superior laryngeal nerve and a recurrent laryngeal nerve. The superior comes across the thyroid membrane. The recurrent comes in the peritracheal groove. And I just want to show you a quick picture of that. That's one of the recurrent laryngeal nerves. Here's a thyroid lobe being taken after it's been taken out. So total thyroidectomy is going to be indicated for any of the high-risk thyroid cancers. So anyone over 45, if they get a positive needle biopsy and they're really suspected to have cancer, you're probably going to plan just a total thyroidectomy. If they're over 45 and you do that intraoperative frozen section, you're going to probably do the completion other side. And we talk to them about these possibilities so they know a little bit more what our plan is when they're asleep. Indeterminate with positive biomarkers and features that prevent option of thyroid lobectomy. So again, this one we did the needle biopsy and it came back with a positive biomarker and there's a high risk of cancer and they have features that wouldn't stop us from doing a total thyroid. In other words, they were over age 45. Then we would probably do a total. Any metastatic lymph nodes in the neck. I just recently, had a patient who presented with a big neck mass and incidentally was found on CT scan, really young guy, 42, and left-sided. And I did the needle biopsy. It was kind of indeterminate, and I wasn't thinking thyroid at this point. It was just a neck mass. I went ahead and took it out, and it came back metastatic papillary. Before I did that, I did an ultrasound of his thyroid just in case, because I was kind of thinking maybe this is possible. It was low in the neck, and it came back with no nodules, 0. So I did the next surgery, which was to take his total thyroid out because he had positive lymph nodes in the neck, like I listed here. And lo and behold, he had 3 papillary carcinomas in that gland that weren't seen on the ultrasound. And one of them was like 2 millimeters, and the one that was probably the source was about 9 to 10 millimeters. So they weren't even that big, but they obviously metastasized fast. The surgery is, the goal of all surgery is to eliminate disease. So the other surgery that we can do is when they do have lymph nodes in their neck is a neck dissection. It's done for all grossly evident adenopathy. Over the years, they've debated when you have a thyroid cancer, should we go in and remove the lymph nodes from their neck just to make sure there's no cancer? And the reason that thought came up is because they did studies which showed that there was up to a 40% incidence of metastatic micrometastasis of papillary thyroid carcinoma in people with small thyroid cancers even. And so that's a pretty high incidence. And it's up to 25% in the lateral neck. So basically what we're saying is a lot of these people do have metastasis. So if you have that high incidence and you took out a thyroid, why wouldn't you remove the lymph nodes in the middle of the neck to upstage them? Because now they would have, if they were over 45, they would not only be a person with a thyroid cancer, but they also have metastasis, so it kind of moves them up a little bit in the staging. And what we found was there are still only 2,000 people dying per year from thyroid cancer. So what was the morbidity versus the improvement of their survival? And it really hasn't changed as much as we thought it would. So neck dissections are increasingly being encouraged only to be done on disease that we can actually see on a radiologic study, and not necessarily going in and prophylactically trying to take everything out to prevent the micrometastasis. And that kind of gets back to what I was saying earlier, is this is the kind of cancer that in some people it kind of lives with you. It doesn't necessarily mean that all those micrometastases will turn into the kind of disease that will go on to be life-threatening. One last thing I put is that metastasis usually follows the transverse cervical artery, and so that goes with that gentleman I told you about with the lymph node that is right above his collarbone. The transverse cervical artery starts from about right here and moves along the collarbone region, and so they get a lot of lumps and bumps in that area to start. So this was an old picture that I've used a few times, and it showed it shows the appearance of if someone had all their lymph nodes out, which segments would be what. So this is levels 2, 3, 4, 5, 6, and 7. And they correspond to 2, 3, 4, 5, 6, and 7 in the neck. And the ones that we see most commonly with thyroid cancer are going to be in this region, although they can move all the way up to level 2, as we've all been surprised by, and they can go down into the chest into level 7, which is right below the sternum. So here's a picture of a neck dissection on someone I did for thyroid cancer. And the jugular vein has been removed because it was involving the cancer. And so here we have the sternocleidomastoid muscle, the carotid artery, the vagus nerve, hypoglossal nerve, and spinal accessory nerve. And I just wanted you to have an ooh-ah picture moment. But it shows that, you know, this the disease can be very extensive from thyroid cancer to have to remove that much tissue, including the jugular vein. This is a picture of a different neck dissection on a different person who had papillary thyroid carcinoma, and his metastasis was mostly in the posterior triangle. And you can see how much, this is the spinal accessory nerve, here's the sternocleidomastoid muscle. So basically we're back in here, and different person though. And we can see that I did a lot of removal because there was a lot of metastatic nodes in there, and you can see a big empty space there where a lot of disease had occupied. So, to kind of summarize, I didn't want to spend a lot of time about all the intricate decisions about surgery. I wanted to give you guys the evaluation of the thyroid nodule. This talk could have gone into all kinds of other complexities, but I just want you to remember, look for those concerning ultrasound characteristics, because you'll see those words, and they're basically trying to yell at you, look into this more, except they won't say that. And then when we get the needle biopsy, then when we do move it on and we get a needle biopsy, understand that there is this option of biomarkers. And when you see those biomarkers, they may have some real indications on when you can watch and wait and when you can move on and do surgery. And then, of course, send them to one of us at Valley ENT, and we'll take good care of them. Thank you.
Questions for Dr. Kell?
Yeah.
Given the high risk of morbidity and mortality with thyroid surgery, what do you recommend to patients who have, like, they'll have a goiter and all the studies are negative and it's just not going away? Do you have any suggestions?
So, indications for a multinodular goiter will be symptoms. And symptoms can sometimes be implied symptoms. If we see compression of the trachea and we think that that's progressing or maybe causing some sleep apnea or other symptoms that they don't really know it's attributed to that, then that would be an indication. Cosmetics is actually an indication. It sticks out of their neck. They don't like it. That's a reason to take it out. And there's a lot more to justify it than just that, because if it's that big, they probably do have other symptoms. Certainly toxicity, so someone who is hyperthyroid because of that multinodular goiter. So it's both big, compressive, and it's causing them toxicity. There's a reason to take it out. It'll be easier to manage them with thyroid replacement. There is a chance of cancer. In nodules that are more than 4 centimeters, there's some studies that have shown up to a 20% incidence of thyroid cancer. I put that into the bigger picture, but a big 4 centimeter nodule is usually also symptomatic. At the very least, it's very big and palpable. And then substernal growth, that's a big one. So we like to catch these before. About 2 years ago, I had this 95-year-old lady who came in with breathing problems, and it was all the way below her aortic arch. And we cracked the chest, did a full thyroid and sternotomy to get this thing out. I did it with cardiovascular surgery, and I remember it was just miserable. I remember thinking to myself, just please make it through this surgery, because you're 95 and I'm doing this huge surgery that I wish we maybe could have taken care of 25 years ago. So I think I tell people about that story when I'm looking at it, I'm like, yeah, you should get this out. And I tell them about the 95-year-old lady. But you look for reasons, basically.
So surgery is the only way to get rid of the goiter?
Well, certainly in a hypothyroid state, they can be replaced, and sometimes some things will shrink. And if you live in the Andes Mountains, I guess you could get iodine. But for the most part, surgery is the treatment. Yeah.
Follow-up after lobectomy.
Say again?
What is the follow-up required after
Thyroid lobectomy? I typically will, sometimes I'll get endocrinology involved. They get a little bit more into dabbling between levothyroxine and a T3 replacement than I do. But I usually do a free T4 and TSH at about 3 to 4 weeks afterwards to see if they're starting to drop. And then I follow them with a few more labs over that year, because my experience is they do drop. My experience also is that over time they sometimes come back up. So they do need to be followed for a little while. But I tell people kind of ballpark 50-50, chance that they're going to need some medication. But I follow them for thyroid levels. I don't usually check anything with the parathyroids. I just thank God and presume that the parathyroids are working.
Okay, this will be the last question, and then we'll move on.
So when you feel a nodule, or what you think is a nodule, and you send them out for ultrasound, and you get those cases where it comes back and it says there's no nodule, but you can physically feel one. With the clinical correlation, would would it be recommended to get maybe a CT scan?
Absolutely. You know, there's a lot of fear on our part and other people's part to not do a CT scan. And when we do a CT scan of the neck, we always do it with contrast. And that's the fear, is that you give them iodine, it may interfere with the long-term treatment plan, which would be radioactive iodine. And I didn't get into that this lecture, but we didn't have enough time. The endocrinologist will tell you, don't worry about the iodine, don't worry about the scan, get the diagnosis right. That's what they worry about the most. They're more worried about missing and treating the right disease than, you know, burning some very short-term bridge. So get a CT scan if you don't believe it. Yep,
With contrast.
with contrast, as long as their kidneys can handle it.